Okay, so I think we're still getting some people through, but I think I will make a start now. So I'm going to open up quickly this webinar with just a few housekeeping notes. So just wanted to let you know that this meeting today is being recorded. The recording will be shared hopefully with all of you by the middle of next week at the very latest, so please do keep an eye out for that. We do encourage you to talk about this event on social media and in other advocacy groups. So please, you can see our handles on the screen there, and I will post them in the chat as well for you. Please post on LinkedIn, Facebook, Twitter with the hashtag #NTDs. During this event as well, there will be time for questions and answers. There is a separate Q&A box as well as the chat box for this event. So please do post your questions in that Q&A box. It would also be really helpful if you could address the name of the speaker that your question is addressed to. That would be great. And then if you have any technical queries or technical questions, please do pop them in the Zoom chat, or you can email us at admin@nnnevents.com and we'll be able to pick it up there as well. But that's everything from me. I'm now delighted to hand over to Yael, who's going to officially open this webinar. So Yael, over to you.
Thank you, Russell, and welcome everyone. Thank you so much for joining us today for this really important discussion, Beyond the River, Rethinking Water and Health. This webinar is hosted by NALA and the Neglected Tropical Disease NGO Network, NNN, and its WASH Working Group. I should say that the WASH Group is co-chaired by Geordie Woods from Sightsavers, who sadly couldn't be here with us today, and Fikra Seife, who you will hear from later. Just before we start, I'd also like to thank Maximize Your Time and Russell for all the technical support for today. So my name is Yael Velleman. I'm Director of Policy and Innovation at Unlimit Health, and I'm a long-standing member of the WASH Working Group, 12 years, and very happy and proud to be part of this great collaboration of people. So before we get started with our speakers today, just a reminder as to why we're here today. So for millions of people around the world, as you all know, rivers, lakes, streams are the center of daily life, for drinking, for bathing, for swimming, recreation, and also for livelihoods through crop irrigation, fishing, and many other purposes. Water is life, as we all know. We also know that when these same water sources are at risk of contamination, they can also be where disease begins. An estimated 106 million people globally still rely on untreated surface water for drinking. And for many more, daily contact with unsafe water and the risks that brings is simply unavoidable. And when clean water, sanitation, and hygiene are lacking, everyday activities become opportunities for infection. This is particularly true for neglected tropical diseases like schistosomiasis, trachoma, intestinal worm infections, and many more thrive where poverty, unsafe water, and inadequate sanitation intersect. As water is an essential part of the transmission cycle, we, as many of us disease control specialists, must remember that that is also where disease prevention has to begin. And this goes beyond infrastructure. It depends also on social and behavior change, community engagement, collaborating across multiple sectors, and ensuring that investment is sustained over sometimes many years. So today we'll explore practical and innovative approaches to addressing the challenges of water and health, from strengthening WASH systems and community engagement to the use of new tools that can help us better understand and interrupt disease transmission. We have great speakers for you today. So before I get to them, I will just take you through a few of the updates on where we are on WASH and NTDs globally. So Russ, if I could have the first slide, please. Thank you. Maybe a helpful framework to get started with. You can see in front of you the best framework for NTD elimination, which was developed by the NNN back in 2016. And the top of the diagram, the B and the E, behavior and environment, is maybe what you would expect to see when it comes to WASH and NTDs. So behavior includes hygiene, and includes hand washing with soap, food hygiene, water contact behaviors, and many more behaviors that affect the risk and exposure to disease. On the environment side, we're looking not just at access to safe, clean water, safe drinking water, but also sanitation. We're thinking also about animals, about vectors, and how animals and vectors intersect with the environment to increase the risk of disease transmission. Less obvious, perhaps, if you're coming to this for the first time, are the aspects at the bottom of the diagram. So when it comes to social inclusion, this is something that we absolutely have to keep at the forefront of addressing NTDs, which are, as I've said, diseases of poverty. So it's about making sure, from the WASH perspective, making sure that services, water and sanitation services, are accessible to people affected by NTDs, including those affected by disabilities related to NTDs, but we're also looking at making sure that those services do not exclude anyone on the basis of stigmatization. In terms of treatment and care, WASH is absolutely fundamental to managing the morbidity associated with NTDs and making sure that the severity does not increase. But it's also about making sure that water and sanitation in healthcare facilities are adequate and don't make infection worse. If I could have the next slide, please, Russ. So, as you can imagine, there's been quite a lot of guidance on this issue from the World Health Organization. And I'm proud to say that the NNN and the WASH Working Group have played a key part in developing some of the materials that we'll cover. So back in 2015, WHO issued the first ever global strategy on WASH and NTDs. And this was renewed when WHO issued the new WASH and NTDs roadmap in 2021. And the current global strategy on WASH and NTDs includes 4 strategic objectives, one on improving the awareness on the benefits of collaboration between the WASH and NTDs sectors, another one on using WASH and NTDs data for targeting services to the people who need them the most. The third one is around increasing the evidence-based and best practices around WASH and NTDs collaboration. And then the fourth one is around ensuring joint planning and delivery and monitoring at the country level. So if we go to the next slide. Thanks, Russell. So last year, the WASH Working Group conducted a process of review of progress to date in the last decade. And I am happy to say that quite a lot of progress has been made over that decade. So just to give you a snapshot, which is definitely not exhaustive, in terms of the first strategic objective, this has included case studies published on the WHO website covering the different approaches that have been used at country level. We've also had a global toolkit on WASH and NTDs for program managers published, also a second version of that has been updated in line with the new roadmap. And it includes also aspects relating to universal health coverage, One Health, and more. And also you might hear from our Ethiopian colleagues that toolkit was also published in Ethiopia for the specific Ethiopia context. We also had training courses in 2 regions of the world, in East Africa and in Latin America and the Caribbean, led by WHO, as well as a course on the WHO Academy. In terms of data, This has been a very challenging area. Those of you who come from the WASH sector know that live data on access to WASH can be very challenging, but we are seeing progress in this area. And on the screen, you can see examples from two countries, Kenya and Nigeria, on joint WASH and NTDs databases that allow decision-making and resource allocation to happen at a much better resolution than previously. In terms of evidence and guidance for best practice, the third strategic objective, 4 countries have adopted national frameworks on WASH and NTDs, which is very exciting, really outlining the roles and responsibilities for delivery, as well as indicators for monitoring and evaluation. And additionally, we had over 130 peer-reviewed publications over the last 10 years, looking specifically at WASH and NTDs. And then finally, on joint planning, we've seen really great progress with ministries of water, ministries of health and education and finance coming together at country level to undertake joint planning and delivery. That's been seen across the board in Cambodia, Cameroon, Ethiopia, the Gambia, Kenya, Laos, Nigeria, and Uganda. And I'm probably forgetting a few examples, but you can see the One Health National Task Force in the Gambia on the screen undertaking joint planning as well. So a lot of progress, but we're definitely not there yet. So if I can go to my final slide. One of the other things that we identified during the review process was a few remaining challenges that we're working to address as a working group and together with the WHO. So we need more data, definitely, on knowing what's going on, who's doing what, if there are better lessons that we can learn from across multiple countries. And while we have a lot of information from the Africa region, we know that there's a lot more going on in other parts of the world that could be shared for everyone's benefit. So that's an area that we're looking at getting more information on. There's a lot more that can be done on innovative financing for WASH and NTDs. Many of you will know that rigid financing makes it very difficult to collaborate across sectors. Ensuring sustainability of the efforts by making sure that they're institutionalized within government processes and structures so that they go beyond specific project cycles. Moving beyond WASH and NTDs, we don't want to create a separate silo. We need to do a better job collaborating with more sectors, taking a One Health approach, and making sure that we're feeding into efforts to improve universal health coverage. And then improving WASH and NTDs data sharing. Great examples from Nigeria and Kenya. We definitely need the same to happen in many other countries. So as a working group, we're currently prioritizing 4 work streams, and I hope that after today, many of you will want to join our efforts. So we're working on improving our work on social and behavior change, building on a quick guide that was developed last year, and I'll post a link to that in the chat later on. Improving our work on better monitoring and evaluation, such as indicators that can be adopted and tools for data collection at country level. Improving coordination at the country level, but also with regional and global bodies such as the WHO and UNICEF. And then also making sure that we are learning on how best to engage communities, because at the end of the day, if we don't have the community firmly in mind, our efforts will not be as effective as they should be. So those are all the slides from me for now, but that's enough from me. I think what you really want to hear is from our speakers from country level. So without further ado, I will pass on to our first speaker, Nisan Zerai Kasete. She's NALA's Ethiopia Country Director, and she'll share her experience on rethinking WASH investment and partnership for NTD elimination. Over to you, Nisan.
Thanks, Sayo, and good afternoon, everybody. Good morning. good evening, wherever you are. I'm happy to be part of this group and now be saying a little bit about the bold move of achieving schistosomiasis elimination by 2030 with strategic use of WASH and partnership between the different sectors. First slide, please. The global health community has a very bold target, which is also the WHO NTD roadmap, aiming to eliminate schistosomiasis as a public health problem by 2030. So for this, we have exactly 4 years left to hit that target. To be blunt, we will never cross that finish line if we always are relying on mass drug administrations. As you all know, medications clear the infection, but if the community returns to the same water source tomorrow to wash, to bathe, to swim, because either the lack of clean water source or the school water system is broken, or the health center's water system is not functional, reinfection is inevitable. We're pouring money into a leaky bucket. So to eliminate or control most NTDs, including the transmission of schisto, we need to rethink our priorities and ensure all the required interventions for elimination are in place. As a global health experts, donors, and policymakers here, we must ensure human waste never contaminates water bodies and find alternatives to safe water points for women, children, and the community at large. Next slide. The NTD sector usually is afraid of WASH investments, viewing it as too expensive or outside their mandates. But we can think strategically. We can think outside the box, not by investing in new infrastructure, but by focusing, for instance, on maintaining the existing ones and ensuring the community has the knowledge and the know-how to sustainably keep that infrastructure running. The WASH problem that we have in the health sector isn't necessarily lack of investment issue. It is a sustainability issue. Global health studies show that 30 to 40% of the WASH infrastructure that costs millions of dollars is non-functional after a couple of years. A broken faucet, a ruptured pipe, a broken valve, in most cases, a very minor issue renders this huge investment useless. That is until we have a plan to sustain the investment and make sure the plan includes local solutions. Next slide, please. This has been tried and tested in Ethiopia through the Watch on Wheels project run by NALA. The concept is very simple. A vehicle equipped with specialized tools, spare parts, and skilled technicians travels directly to schools and health centers in high NTD burden areas, not to build new infrastructure, instead to assess and rehabilitate non-functional water infrastructure. For every single dollar invested in the Wash on Wheels model, one child gains reliable access to water for an average of 400 school days. This model is very fast, is cheap, and sustainable. However, the key success of this model doesn't just rely on the maintenance and the cost effectiveness. It relies on the human strategy. The team doesn't just fix an infrastructure on one. At every single stop, they provide comprehensive theoretical and practical training to local district water officers. They arm these government water technicians with the tools and technical skills to diagnose issues, maintain systems, and fix minor technical breakdowns before they actually turn into system failure. This is how we move from temporary aid to permanent government ownership and institutional sustainability. Next slide. Next slide. Oh, thank you. Yael was mentioning about cross-sectoral collaboration, and this is one other important thing what we shouldn't be missing. As I mentioned earlier, It isn't lack of investment in WASH that is the issue. The WASH sector invests around $10.5 billion annually in our continent alone. The NTD sector needs to leverage this. The sector can partner directly with established water partners, local water bureaus, or the private sector by providing these partners with epidemiological data, guiding their investment into NTD hotspots. We provide the target data, they provide the infrastructure footprints. The multi-sectoral approach, which is also tried and tested in Ethiopia, has been a WHO flagship strategy. The strategy drives shift from isolated health interventions to cross-sectoral collaborations between health and water sanitation sectors and beyond. The framework of the strategy prescribes that sectors work together by targeting high-risk areas, integrating data, and implementing and monitoring together for a better health outcome and for a higher impact. We have exactly 4 years until 2030. If we continue with business as usual, pouring money into separate, siloed interventions, only mass drug administration campaigns, and short-lived construction projects with no sustainability plan, we will miss the deadline. To the donors here today, the call for action is allocate structural, flexible budgets specifically earmarked for operations, maintenance, and the training of local personnel. Demand to know how many systems will stay functional, not just how many will be built. To my fellow experts and government representatives, working in silos haven't brought the change that we have worked on for years. Now is the time to think strategically and in partnership, bringing on innovative ideas and ensuring that the gains made through the years of investment and hard work are sustained and NTDs are eliminated across the globe. Thank you.
Thank you so much, Nisan. That was a really great and inspiring presentation. I think the key message really is that sustainable disease prevention doesn't end when the infrastructure is built or repaired. Otherwise, as you say, we're pouring money into a leaking bucket or indeed flushing money down the toilet. So that is wonderful. I will now hand over to our next speaker. He is Asrat Meleko, NALA's project manager and a PhD candidate. Asrat's research focuses on schistosomiasis transmission and prevention, and he'll share how understanding the interaction between water, people, and the environment can help inform more targeted disease prevention strategies. Over to you, Asrat.
Thank you, Yael. Good day, everyone. Thank you for joining us. My name is Asrat Meleko, project manager researcher at NALA Foundation. Over the next few minutes, I would like to share how we work with the community to identify schistosomiasis transmission hotspot, understand the determinant factors, as well as changing the evidence we got from the mapping into local community-led prevention. Globally, over 250 million people are at risk of schistosomiasis transmission, and the transmission largely sustained across sub-Saharan Africa, where over 80% of cases are reported, as you can see in the highlighted part of the map. Over the last few decades, mass drug administration program expanded access to treatment and really brought a significant reduction in disease morbidity. However, despite this successful control efforts, the transmission of the disease still continued in many endemic countries due to reinfection even after taking the treatment. The main reason behind this is the transmission of schistosomiasis is highly focal and localized. Even when the overall prevalence shows a decrement, a few hotspots can still continue to sustain infection. To understand why schistosomiasis transmission still continued across different countries, it's important to understand its connection with water. It's fact that schistosomiasis is basically a water-based disease. It starts when people interact with the water that harbor snail and the parasite that contribute for infection. So these freshwater snails release cercaria the infective stage of the parasite, which create an opportunity for infection across the different communities. Since daily activities, including domestic purpose for agricultural and also for recreational purpose, involve repeated water contacts, the transmission of schistosomiasis occur at a specific and commonly used sites, which is common in most rural settings. Therefore, understanding these sites is very crucial to interrupt transmission and move towards the elimination goal. So this is the place where we start our activities. So the next question was, how do we find the specific sites where people interact with the water, which is very important to proceed to the next activities. Thus, our starting point was the community. The guiding principle behind this activity, actually not only this activity, behind NALA's implementation approach across different projects, communities are not passive beneficiary or just research subjects. They are the partner, they are also true expert of their environment. So we believe that when to create a lasting and sustainable solution, it's important to empower the local community to identify the problems, designing solution, and also leading the changes in the implementation as well. As a part of this, we recruited a community volunteers when we start this activity. So these volunteers become like a champions of the research and also the implementation activity. Initially, we provided a capacity building for these community members regarding snail collection and also the upcoming activities. Then using these community members, we identify the water contact sites, which is very important. And the communities are well now their environment since they are living in that area. So the next question was, after identifying the specific water pointers, which of those sites actually harbor the important snail species as well as the parasite? So here we revived a malacological survey to understand the transmission pattern of schistosomiasis and also understand the spatio-temporal distribution of snails transmitting schistosomiasis. So in this survey, we addressed 172 water contact sites across different regions in South Ethiopia, in 3 different regions. And we collected a comprehensive data from the ecology and from human and also geospatial data. So the collected data, such as the snails and also the water quality parameters and also the parasitological examination was conducted after transporting the samples into a nearby laboratory. The snail was, we identified the snail species based on their morphology and held examination for shading, whether they are actively infected during that time. So this all comprehensive data was very important to generate a risk map and provide evidence for targeted and also efficient interventions. So after collecting all those data from the field, we did analysis. So the analysis showed that snail distribution was not random. It was determined by specific environmental factors. As you can see in the forest plot, muddy substrate and dense vegetation, especially the taro, which is common across different parts of the southern Ethiopia, was found to be a determinant factors for snail abundance as well as snail presence. So as you can see, these variables are modifiable that can be changed by the involvement of the community. The other important variable was the hydrological flow. It acted as a limiting factor. So slowly flowing water was very suitable for snail abundance and also suitable for the transmission cycle. So the next important question was, after understanding the different environmental factors, it was important to ask which factors, both environmental and behavioral factors, are determining infection of people with schistosomiasis. So snail abundance and infected snail presence was the major factors increasing exposure risk. Those sites with high snail abundance and also infected snail presence have high odds of infection in contrast to the other sites. The other is the human variable, swimming and playing also a significant variable contributing for transmission of schistosomiasis. The other is proximity to market and proximity to school, which is related with human settlement. So this also contributing for the sustained transmission of schistosomiasis across different sites. Identifying the transmission hotspots and classifying those sites based on risk was not our final goal. Our final goal was using those evidence and designing locally suitable intervention strategy with the community and leading to the transmission interruption. So we held a community action planning workshop. So in this workshop, we reviewed the data from the mapping, and also we developed a solution for the problem. So this suggested community-led action involves the environmental management, such as vegetation clearance and removing stagnant water, and also wash activity and targeted social and behavioral change communication for peoples living around the water edge, and also for agricultural peoples around the water. To summarize my presentation, single intervention cannot interrupt transmission, because as we saw in the previous slides, ecological, behavioral, and social factors are the determinants of transmission. Therefore, a holistic, multidisciplinary approach is crucial to transmit interruption. The other is snail mapping and eDNA surveillance are crucial for targeted and predictive elimination efforts rather than reactive efforts. Due to shortage of time, I couldn't present the eDNA-related activities we are working on to complement the surveillance system for precision hotspot identification. Anyone interested to hear about what we are working with the eDNA and other activities, we are happy to share that. And last, the community engagement in the problem identification, co-design, leading the intervention created a durable, locally owned and sustainable hotspot control. So final word, this research and also the implementation activity could contribute for future researches that could help the move towards the elimination goal. Thank you so much.
Thank you so much, Asra. That was really fascinating and so informative. I think it's easy to make the assumptions that if we just do WASH, disease will be prevented, but actually, as you've pointed out, not all transmission pathways are covered by standard WASH services, and this is exactly the kind of information that we need to know how services should be tailored to both meet the objectives of community needs and disease prevention. So thank you so much, and wish you all the best with the continued research. Okay, so we will now move to our panelists. So to take us through the next session, I would like to hand over to Fikra Seife, who's NALA's project manager and is the co-chair of the NNN's WASH Working Group. Fikra will take us through a discussion on lessons from country experiences and what it really takes to achieve sustainable disease elimination. Over to you, Fikra.
Okay, thank you so much, Yael. Can I get the slide just please? Okay, wonderful. So thank you so much, Yael, for the introduction. And thank you so much to our great panelists, great speakers, the previous speakers who have shared their insightful presentation, Asrat and Nissan. So now we will move into the panel discussion, our next session, which is country's experience and lesson learned from the ground. So for this, Today, I'm joined by four great panelists from Egypt, from Ethiopia, from Kenya, and from Tanzania. So from Tanzania, we are joined by Mohammed Niati. Mohammed is a seasoned public health officer with over 30 years of experience in disease prevention and primary health care. Currently, he holds the position of national focal person for schistosomiasis and soil-transmitted helminths at the Ministry of Health of Tanzania, where he leads initiatives aimed at controlling and eliminating these diseases. Over the past 6 years, Mohammed has spearheaded various strategic initiatives in collaboration with both national and international partners for further Tanzania's agenda for elimination of neglected tropical diseases. And our second speaker will be Aida Binali from Kenya WASH Alliance. Aida is a WASH specialist with over 20 years of experience in water sanitation, hygiene, public health, and development. As a program coordinator at WASH Alliance Kenya, she collaborates closely with government, different government entities, development partners, and communities to promote sustainable WASH service and enhance integration of WASH and neglected tropical disease initiatives. Aida possesses extensive experience in WASH governance, policy advocacy, multi-sector coordination, all of which are very essential in accelerating progress towards disease elimination. Our third speaker will be Anton Makonnen. Anton is a strong senior public health professional with over 20 years of experience specializing in sanitation, hygiene promotion, social and behavioral change, and neglected tropical disease programs. He currently holds a position of senior social and behavioral change and WASH expert at the Federal Ministry of Health, Ethiopia. His areas of expertise include multi-sectoral coordination, policy advocacy, and design and implementation of evidence-based interventions. The last, but most importantly, we are also joined by Dr. Sameh Al-Martomi from Egypt Ministry of Health and Population. He is a public health specialist with extensive experience in the control of neglected tropical diseases, particularly schistosomiasis and soil-transmitted helminths. He previously served as a director of schistosomiasis and intestinal parasites to control parasites control at the Ministry of Health and Population in Egypt. And he has played a great role in surveillance, disease control programs, and national NTD elimination efforts. Thank you so much, all the panelists, for joining this evening.
Thank you.
Next slide. Okay, so fantastic. Now I will move on to the questions that I would like to forward to our great panelists. So the first speaker will be Mohammed from Tanzania. So Mohammed, despite an ongoing improvements in the water sector, as we know, many NTDs endemic communities continue to face challenges related to access to safe and reliable water sources. From an NTD prevention perspective, what are the most critical gaps you continue to observe on the ground? And how do those gaps influence NTD transmission and elimination efforts? Over to you, Mohammed. You have 3 minutes to reflect your thoughts.
Thank you, hello everybody. You know that for the past few years, there's a lot of investments in progress in the water sector and WASH in general. And despite these significant investments, many NTDs, endemic communities, continue to experience limited access to safe, reliable, and conveniently located water sources. And we all know that a lot of NTDs are in the rural areas. And in the rural areas, households often rely on rivers, ponds, dams, and other open water bodies for domestic activities. But these practices results in frequent human water contacts, which sustains the transmission of water of water-related NTDs, particularly schistosomiasis and other entities. So the major gap we have here is that there's an inadequate coverage and functionality of water infrastructures, with some existing facilities being seasonal, and many of these seasonal facilities are poorly maintained, or some of these facilities are unable to meet community demands. And access of these facilities, or access to improved sanitation in the hygiene facilities, it remains insufficient in many communities. So leading to environmental contamination, and it we continue reinfection and the reinfection of these entities. So also there's a limited integration between WASH and NTD programs. This is one of the gaps we have. A lot of WASH programs, they are separate from NTD control programs. So the integration is very, very limited. And this, it reduces the opportunity to address the transmission drivers comprehensively. And so these gaps directly affect the NTD elimination efforts, and it increases the risk of reinfection even after repeated mass drug administration. We have been doing mass drug administration for almost 10 to 15 years now, but because we are not integrated, then the efforts are limited, and the risk of infection is very, very higher. And so the sustained progress toward elimination will require targeted investments in safe water supplies, sanitations, infrastructures, hygiene promotion, and stronger coordination between the water sector, health sector, education sectors, and community development sectors. This will help us to reduce the exposure and make sure that maybe by 2030 we can have eliminate or interrupt the transmission of these diseases. Thank you.
Great. Thank you so much, Mohammed, for that interesting point. So the points you raised are exactly aligned with previous speakers, Asrat and Nissan. So still, we are continuing with several challenges like access, integration, and yeah. So we will see. We will hear more on this from the next speakers. So thank you so much for that. So I will proceed to the next speaker. I can't see the last slides. Okay, thank you so much. So now we are with Aida. Aida, you have closely worked with both the WASH and NTD sectors during your service at Kenya WASH Alliance. So from your experience, what has worked best to translate policy discussions into a measurable action? Over to you, Aida.
Thank you very much, Fikri. Good day to everyone. I'll just jump in. From experience, we've seen that effective way of translating policies and discussions into measurable action is moving beyond coordination meetings and ensuring that policies are domesticated and operationalized. Maybe we're looking at through joint planning, joint implementation, and joint accountability mechanisms, both at the national, at the county, and the community levels. From the WASH Alliance experience, we keep asking ourselves, what does success look like? And maybe how do we break into actionable components or breaking the silos that already exist that has been spoken about with the previous speakers? And how do we meaningfully align these outcomes to contribute to the WASH NTD goals? So we look at different strategies. And the strategies, the first one I would say is supporting the multi-sector coordination with very clear roles and responsibilities. What has worked best is bringing about the different departments, that is health, water, education, finance, and even just national and county governments to speak to each other with a common goal. And we prioritize resources, targets, and make sure that we are leveraging in the strengths of these different partners that we talk about, just to complement each other's efforts. Just as an example is maybe the NTD program will look at identifying transmission hotspots, and the WASH actors can prioritize sanitation and hygiene investments in these areas. So when we form, let's say, a community of practice or a technical working group where people are able to share experiences and learnings, we transform these commitments into targeted interventions on the ground. We'd ensure that the government is also just supporting and leading these processes. The second strategy that we've looked at is using data to drive actions of implementation at the community levels. So when you look at what has been spoken before, we have to support all these initiatives or implementation investments with evidence. Through this, we've found out that collaborating the NTD prevalence data and the WASH data can help identify communities that have poor sanitation or unsafe water. We can identify these ones and also identify the intended actions that need to be done. And big example what we've done in Kenya is through the support of NFund, the Ministry of Health and other partners. We've been able to develop a dashboard that we overlaid the WASH data and NTD data, prevalence data, just to overcome the fragmented data systems that are there and to support strategic planning and in the endemic areas. We hope that this dashboard, or of course it's being hosted by the ministry, will help in supporting evidence-based decision-making and brings together now the different partners can be able to identify the high-risk areas, target investments, and even monitor progress of this action. The other principle that we look at is the community-led approaches, where policies will succeed where communities are actively involved in joint planning, implementation, and monitoring. As a sector in Kenya, there's promotion of community-led total sanitation, there's supporting the school health clubs and the community health promoters work, the routine work, just to ensure that there's ownership, and this increases the sustainability. Because we all understand communities will sustain these sanitation gains and even adopt these healthy behaviors if they are put into and work within the solutions, rather than just being beneficiaries or being externally driven by different people. The other strategy we look at is WASH should not operate as a parallel program. So it should be integrated in all the NTD programming. And an example is just incorporating hygiene promotion when you're doing deworming campaigns or using the school-based deworming programs to reinforce hand washing or sanitation messaging. And another one that we have done as a country is engaging community health promoters to deliver both NTD and WASH messaging during the household visits, so that it goes as a package, and this increases the efficiency and strengthens prevention efforts at the community level. Lastly is just ensuring that we have measurable indicators and accountability. I know policies discussion always fail when there are no shared indicators. So here we are struggling different sectors because data is still fragmented and hosted at different platforms. So for successful implementation of this, we would propose that we have we have tracking of access to sanitation, water services, ODF, open defecation free status, the prevalence and reinfection rates, all having the same indicators, and having regular meetings so that we're able to assess the progress and make course corrections between all the stakeholders. Yeah, so in summary, I would say that policies become impactful when the results are tangible, improvements in WASH, in disease transmission at county level, and in all these aspects, the government should take leadership and ownership so that they're integrated into the government systems so that the policies can be actionable. Thank you.
So many great pointers from Aida. Thank you so much. As Aida said, so having a policy by itself is not an end. Rather, a policy, a strategy, and political commitment should be translated into an action, into the community level, into the ground. So for that, there should be proper data that are coming and analyzed, translated, and used for decision making, engaging the community, and so on. So as previously during the introduction, Yael was mentioning Kenya and Nigeria as a pioneer countries for this translation, translating policies and strategies to action. Thank you so much, Aida, again. So the next speaker will be, Antaneh. First speaker will be Antaneh from Ethiopia, and followed by Mohammed. So Antaneh and Mohammed, while preventive chemotherapy has been an instrumental in reducing disease burden, we know that achieving elimination requires sustainable prevention approaches. Based on your country's experience, which is Ethiopia and Tanzania experience, what lessons have been learned about combining treatment with WASH and behavioral change communication interventions? Together with this, what operational and strategic challenges still need to be addressed to accelerate the shift towards a more prevention, which is WASH-focused model? First, Antaneh.
Okay, thank you, Fikra. I think in our country experience for this area, chemotherapy alone is not insufficient. We face for the resurgence of diseases of trachoma, schistoma, and stage, other diseases as well. The environment should be safe. We launched the multi-sectoral coordination, more than 700 districts. The toolkit we translate into 5 local language and cascade the training to the task force, the Warada task force, technical working group. So increase the awareness of those political leaders at Warada level, the link between WASH and NTD. So the benefits, working together is a benefit, and how we work together, and so on, how to understand the situation, and so on. So after this, we piloted different social behavioral change model in different zones, like in Arise project, international transmission project, state focus, and the Accelerate project, low and moderate endemic area in lowland and areas. So those project-based approach are most effective. So all parallel intervention, the antibiotic, the access to adequate and safe water, as well as sanitation, is parallel implementation can bring radical change. So we have seen such kind of lessons from the different projects. But in regarding with Ethiopia context, Ethiopia has an opportunity to have multi-sectoral coordination, which is called One WASH National Program, which is established starting in 2013 Gregorian calendar. So this platform is an enabling opportunity for WASH NTD coordination. So the National Technical Working Group, those platform members from 4 sectors, the water sector, education, health, and finance sector, all of them are the member of the technical working group, both at national and regional level. So they understand how we work together. So after a lot of advocacy, NTD is a selection criteria for WASH investment, for One WASH national program. So this is one of our success. But one of the big challenge for using WASH NTD data is NTD has clear mapping at Warada level, but the WASH data lack of consistent and complete data at Warada level. Of course, we have national level, but in each Warada is lacking consistent and complete data to conduct data merge. So this is one of the big challenges for our scenario. Thank you.
Okay, thank you, Antana. So with that, let me proceed to Mohammed. So Mohammed, how do you see this from your country perspective? What will be the added value of integrating medication, preventive chemotherapy with extensive WASH and PCC interventions? And what are the challenges that we couldn't overcome yet?
Thank you very much, Fikri. You know, in Tanzania, we have been doing mass drug administration for almost 15 years now, and I think it's 15 to 16 years. And our major experience is that the MDAs using albendazole and praziquantel as the preventive chemotherapy is highly effective in reducing the burden of schistosomiasis in the STH. And however, treatment alone is not sufficient. We want to achieve control and the elimination of these diseases by 2030 or before 2030. But we have been relying on mass drug administration for quite some time. And we have been doing mass drug administration, and in some of the areas, the prevalence has been reduced and the infection has been reduced. But there are reinfection in some of the areas. Some of the areas in Tanzania, which we have been, the coverage of WASH and sanitation is very high, because we have WASH sector in Tanzania. We have in the Ministry of Health Tanzania, we have WASH and sanitation department, which they are mainly doing WASH and sanitation part. Some of the areas in which the sanitation data is very good, they have very good coverage of water. They have very good coverage of toilets. The disease has been reduced to less than 1% in some of the areas, and also for STH in less than 2%. But in some of the areas in which the coverage of water WASH is not very good, then remains the prevalence remains to be very high, and where frequent contact of with water is continue, and people in those areas, they continue to go and use water which are infected, and then the reinfection of the disease continue to occur. But one key lesson we learned from that is that the integration, if we integrate treatment data, I mean, if we integrate treating schisto and STH using praziquantel and albendazole, and if we integrate those interventions with WASH improvements, and then we make sure people change their behavior, then there is significantly enhance the impact, and also the sustainability part will be achieved. So our efforts is to make sure that we can control and eliminate schisto and the STH. But if we do not integrate these 2 or 3 interventions, the mass drug administrations, the WASH part, and also the behavior change, then we cannot achieve what we are planning. If for health education, if we deliver health education through schools and communities, we increased awareness of disease transmission and prevention, while collaboration with water and sanitation sectors has helped us in address some of the environmental factors that sustain the transmission. So in those areas in which these 3 issues, then the transmission has gone down. But communities with improved access to safe water and sanitation facilities, they often experience lower risk of reinfection and greater long-term benefits from treatment programs. We have regions like Arusha and other regions in which Sanitation program is very good. They are aware of what we're trying to achieve. Then there's the infection has been reduced to less than 1% for schistosomiasis and also to less than 2% for STH. But despite this progress, several operational challenges are still, and there's a challenge remaining. So we have some of the operational challenges, and also we have some of the strategic challenges. There's a coordination between these three sectors or four sectors, means the health sector, water sector, education sector, and the local government authorities. There's some challenges in coordination, and there's often different priorities. So we have different priorities. We have different planning cycles. We have different funding mechanisms. These challenges are affecting our goals. So the WASH interventions.
Mohammed, so for the interest of time, can you quickly wrap up, please?
Thank you. I will wrap up. So for WASH interventions are typically more resource intensive. So our WASH sectors have very good resources and require longer implementation timelines. And also in behavior change is a gradual process that requires continuous community engagement, particularly in rural and hard-to-reach areas. But to accelerate the transmission toward a prevention-focused model, a greater investment is needed. So we have to integrate these sectors and make sure that we can do a precision public health approach that combines epidemiological data with WASH data and environmental information that can help us to prioritize the resources and ensure that interventions are directed to communities where transmission persists. So this will help us to support the long-term goal of the emissions.
Thank you. Thanks so much, Mohammed. So with this, I don't think I have much time to continue to the next one question. So I will directly proceed to Dr. Sameh from Egypt. Can you? Yes. So thank you so much for joining again, Dr. Sameh from Egypt. So first question for you is, Egypt's success highlights the importance of addressing the underlying drivers of schistosomiasis transmission. Could you share Egypt's comprehensive approach and how it complemented preventive chemotherapy to achieve a sustainable and lasting impact? Thank you.
Okay. Thank you, everyone. First, I would like to say I'm very honored to join you today in this important discussion. Egypt experience has demonstrated that achieving sustainable control and progressing towards the elimination of schistosomiasis require far more than medical interventions alone. In Egypt, we have established the National Schistosomiasis Control Program 50 years ago. One of it consists of four main pillars. The first one is examination and treatment. Second one is snake control. The third is health education and community participation. And the last one is environmental sanitation and management. And I can say we do all together in parallel approach. First one is examination and treatment. We have active and passive surveillance system in Egypt. Passive is a collection of cases data from official reporting sites. Active surveillance, we use it for active search of cases in the community, household, or schools. Used as the disease is target for eradication or elimination, and to verify interruption of transmission. Active surveillance, we have 100 random sample per month taken within the scope of each rural healthcare unit. Also, we have 10 visitors per day in every healthcare unit that clinician can refer them to the laboratory for free testing without any symptoms. Also, we have annual examination for school children in every rural area. Snail control is very crucial. We have snail control by mechanically or chemically using nucleosamide. Also, wash services and environmental sanitation is very important. We have presidential initiatives, Haya Karima or Decent Life, starts from 2080 for rural areas development, including wash services to achieve sustainable development to rural areas. Once villagers are provided with sanitation and safe water supply, there will be a long-term reduction in the contamination of snail habitat with schistosomyces eggs and the reduction in human contact with Cercaria infested water. Also, media campaigns is very important. We have it in media or in schools or in every site of infection. Also, the training of our colleagues in labs is very important. So we have annual training for them and on-job training if we need. This is how Egypt
Thank you.
for now
Okay. Yeah.
could control schistosomyces. I know that the time is not long
Yeah.
to say again.
Yeah. It's, sorry for the short time.
Thank
And
you.
we all know Egypt is can be mentioned as an example for schistosomiasis reduction. As I know, LF is also eliminated in Egypt and other entities as well. So, Dr. Sami, just quickly, can you comment on the government commitment as well as multi-sector collaboration in Egypt?
Okay. We have a strong political commitment and a multi-sectorial collaboration between Ministry of Health for treatment and surveillance, as I mentioned before, and other ministries like irrigation and agriculture. So this is crucial because they are the only ministry that have the key role in removing of aquatic vegetation from waterways for the effective utilization of snail pesticide. And also the media campaigns is very crucial. As I mentioned, Haya Karima, the presidential initiative, collecting all ministries together for helping rural areas to have the safe water in every village in Egypt. And I saw this is very important for schistosomyces control.
Thank you so much, Dr. Sami. I wish we could have a sufficient time and learn a lot from this great experience of Egypt. Yeah, so I think I have to wrap up the panel discussion here, although I have some remaining questions for our panelists, but in interest of time. As you understand from all the panelists, so water access should not be measured with average, rather should be measured. Should be measured through the lens of equity. as many NTD endemic communities are still lacking safe water access, while the coverage is high in that country. So equity is very mandatory. And the common message from this panel is that sustainable NTD reduction requires extensive prevention interventions. So no one has doubt on the impact of MDA, especially for short-term reduction. But the question is, when we think of sustainable and long-lasting impact. So for that, so water should not be treated as a developmental issue. Rather, it should be considered as a means to break disease transmission cycles. So thank you so much, all the panelists once again, and the audiences, of course. And hopefully I will see you, some of you, very soon. So over to you, Yael.
Thank you, Fikra, and thank you to the panelists. Every time I hear all of you speak, I learn so much. I think it's been a really valuable panel for everyone who's participating today, and I'm sure a lot of people will be reaching out to you with additional questions. From my side, I think we've heard that there isn't one single solution, and that we really need to fire on all cylinders, whether it's infrastructure, behavior change, strong government ownership, community involvement, and as we've heard from the example of Egypt, political buy-in is absolutely crucial to ensure that the efforts are sustained. Okay, so we will now go to our final speaker before we go to the Q&A, and I'm delighted to say we're joined today by Ida Maria Meda, who's the Malaria and NTD Global Technical Lead at UNICEF. UNICEF have recently joined the NNN as official observers, and we're so happy to be collaborating with the agency and with you, Ida. So I'll pass on to you to hear your thoughts about what you've heard here today. Over to you.
Thank you very much. And I'm really pleased to be on this webinar. I think it was extremely insightful, and it provides the sort of lens that we need to do more in implementing within the NTD space. And so what are my thoughts? I will not even try to bring in anything new. I will give a quick top-line summary of what I've heard, because I think I cannot do better than that. So Nissan started off with a rousing call to action. Asrat provided the evidence of what works. And the distinguished country panel, Mohammed, Ida, Antene, Same, and Fikre, shared really great context and solutions that have been proven at the local level. And we have here with us a sobering reminder that we only have 4 years until 2030, and that we need to do things differently to fast-track progress. So a summary of what I've heard, and which I think is important for us to keep in mind, is the first is around the fact that the WASH sector has a huge amount of infrastructure and partnerships, and we need to mindfully leverage that for NTD control. And work with WASH to move away from siloed implementation. The second, which could be the first, in fact, is that we cannot do this without strong government leadership. And that's particularly critical for multi-sectoral coordination. Different ministries need a higher level to bring them together at the ministerial level. And they need joint accountabilities. I would say the third and equally important lesson today is that local solutions work. Nissan's example of WASH on wheels was fantastic. And she flagged some of the issues we see in rural areas, which is a small break in the water line, which unaddressed quickly becomes a burst pipe, water running for days, and a community that goes without water for weeks on end, which could have been fixed by a very quick and small solution, you know? And there are more and more of these examples, I'm sure. Another lesson I feel is the adaptation of tools and approaches to the local context. The mention of the NTD WASH toolkit, the translation into different local languages, and the deployment to the community level. That was great. Is this something we can do in other places? Community-led action. We frequently talk about the community, as Asrat mentioned, as passive recipients of support. But in fact, in his study, they played a role in identification, design, and implementation of solutions to interrupt transmission, rather. Multi-sectoral approaches are not, by the way, they need to be at the heart of all of our work in elimination of NTDs. And then finally, we keep talking about precision public health. And this is where it comes together, really. The evidence, the data that can help us to target better and to support programming. I think with that, I'll thank the panelists and the team. This was excellent. Thank you very much.
Thank you so much, Ida, and thank you for expertly summarizing so much of the richness of today's discussion. And thanks a lot for being here today. Okay, so I think we have a few minutes for a couple of the questions. Please forgive us for having to be a little bit selective, but the quicker the answers we get, the more questions that we can include today. So I'm going to put the first question to Dr. Sameh. So, Dr. Sameh, the question to you is, it seems that you have a very rich and valuable experience in NTD control. Could you please share some key achievements of the national program, as well as key lessons learned and recommendations for future programming?
Okay.
Go ahead, we can hear you.
Okay. Lessons learned. I will be specific. First, strong political commitment is essential. The second, multi-sectorial collaboration makes the biggest impact. Mass drug administration is a cornerstone, and we are in Egypt have two factories that manufacture praziquantel. So we have available praziquantel to make MDA and for any case. Snail control also. We have two methods, as I mentioned, of control, chemical and mechanical. Because we're eliminating snails reduce the chance of reintroduction of the parasite. Of course, wash improvement matter, expanding clean water access and the sewage systems decrease contact with contaminated water. Community awareness is a fundamental drive. The importance of early treatment and prevention methods in continuous education, which increase treatment compliance and change behavior. Sustainability is the main objective today. Maintain surveillance activity even after low prevalence was achieved. Ongoing monitoring to prevent new hotspots from emerging. We have all our activities performing using a domestic fund. Data-driven decision-making improve outcome. We have to prioritize resources, target interventions, measure program impact, and also ensure laboratory preparedness by providing permanent testing supplies such as cups, tubes, glass slides, and CATOCATS kits. I was I was short.
Great. Thank you so much,
I
Dr.
know the
Sameh.
time is
There's
crowded.
clearly so much that we can learn
Thank
from
you.
you. And if there's anywhere we can find information online, please do pop a link in the chat for the participants.
Okay.
I think we've got time for one or two more questions. So I'm going to, this question was for all panelists, but I'm going to pick one. Ida, I hope I can pick on you, Ida Binale. So could you tell us if you think that there are any blind spots in the sector from your point of view, in terms of WASH or other requirements that we don't address at all right now?
Thanks, Yael. I think we are addressing it, but not so much that to the recommended levels. One, we are not mapping the high-risk communities. So we are leaving them behind in our initiatives, and I'm talking about, the fishermen, the miners, the prisoners, the groups like that. So we need to do more on that because we're leaving that community aside. And then the other one that we have not done so well is that WASH is still treated as a supportive add-on and not as a core NTD initiative. So this is something that we need to bring into focus instead of being designed as a support, but just as a package from the start go. The other thing is the behavior change. Of course, it cannot happen just in a short span. So there's a tendency of just looking at infrastructure and not looking at the behavior change, which takes a bit more a longer period of time. So there's a lot that is being left out. And then also in the schools, we're just looking at MDA and we're not looking at how the schools and the healthcare facilities can be the frontline platforms for where there's a lot of leverage we can do in terms of WASH NTD initiatives or integration. Thank you.
Thank you so much, Ida. I really agree with all those points. And I think there are a few more contributions in the chat from others about other populations. I think street children, populations in conflict areas. And I think I would probably add to that maybe also animals and animal-related transmission factors. A lot more than we can cover. Great, thank you so much for that. Maybe I can direct the next question to Nissan. So Nissan, what are the new and innovative ways of blended finance that NALA is using to reduce regular donor dependency methods?
Thanks, Yael. And I think it's a very good question when we're talking about domestic financing and sustainability and stopping donor dependency. If I can give the example of WASH on Wheels, when we started the project, it was a pilot project that was funded by the Gates Foundation. It was a very small pot of money. Once we started the project, what we've noticed was 40 to 60% of the resources and the funding was actually coming from the community. So when we saw that the community was engaged and supporting, we actually stopped and started recording how much the community is bringing. So we see ourselves as catalysts. We start the process, we do trainings, we work with the community, and then once they own it, we can go out and in some areas we have over 90% functionality rate after we left, a couple of years after we left. So that shows no parent, no family wants their kid or themselves to be sick or to not use the water resources that was built. It's just a system failure about how to sustain it. So I don't think we will have any trouble in the future. We keep on integrating what we do with the community itself. They will own it. And we have seen it in the WASH on Wheels project. So that is the key. We work within the community, not parachute in and parachute out.
Wonderful. Thank you so much, Nissan. And I'm sure there's a lot more that you can say about this topic, which is absolutely fundamental. We've got time for one more question. So I will put that question to Asrat. And this is about whether in the work that you've described, you've been able to put together a sustainability plan for the community-led initiative.
Thank you, Yael. So as I mentioned before, sustainability and community ownership is one of the major thing we are working on. So when we start the activity, that's the reason why we started by recruiting the community and enabling them how to identify the hotspot area, design the intervention, and finally lead the changes as well. In addition to this, we have a plan to integrate. Actually, this is happening from the start. We are anchoring all the activities in the academic institutes. There are universities in different sites, so capacitating universities to work on the malacological research and also leading the research activity in their locality. Moreover, the intervention are also integrated into other similar programs, like, for example, for the snail intervention, for the vector control, we have to work on the vegetation removal and also stagnant water removal. So to integrate to the existing system and other activities as well, we integrated with a malaria program. So these are some of the activities we have been doing. Overall, the activity starting from the inception to till now is happening in the integration with the existing system, with the academia, with the government as well, and the community. Thank you.
Thank you so much, Asrat. And I really have to emphasize there's so much to learn from the approach that Nala has taken for making sure that the work that you're doing is really community driven and really based on the needs and the preferences of the community, which ultimately makes the work so much more sustainable and effective. So thank you so much for covering all of that today. Okay, so I think we are out of time, so that it remains for me just to close us up for today. So first of all, I just want to say thank you again to all the presenters, the panelists, to Nala, to the NNN and to MYT for making this webinar a reality. I hope that all of you who still have questions and still want to learn from the experiences that have been shared today will be able to reach out to the different speakers and follow the links that were shared in the chat. As Russell mentioned, we will share a recording of the webinar as well with everyone who is registered. So please do check that out when it's ready. And just to say, again, to emphasize, if we are serious about eliminating NTDs, we have to continue investing not just in treatment, but also in prevention. And that prevention has to start when transmission begins at the water's edge. So thank you so much, everyone. And we'll now close this webinar.